Hello, I'm Dr. Mary L. Jessup, and I'm here with Dr. Scott Solomon to talk about heart failure cases. We've got some good cases today, Scott.
Super.
Let me start, please. So I call this the case of the frequent flyer. Mr. Baxter is a 57-year-old African-American male. He's now in the emergency department with acute decompensated heart failure. We know he has single-vessel coronary disease, about an 85% occlusion of his distal right coronary. It's out of proportion to his severe biventricular dysfunction, with an ejection fraction of his left ventricle of 15%. His echocardiogram and his past admissions have shown an enlarged right ventricle and left ventricle with really poor contractile function, moderate mitral regurgitation, and moderate pulmonary hypertension. He has a long-standing history of hypertension. He still smokes 10 cigarettes a day and uses alcohol daily, at least 2 to 3 beverages a day. He lives alone, and he's estranged from his children. In the last year, he's been hospitalized 3 times. He was last discharged just 2 weeks ago. Here's a list of his medications, Scott. He's on a lot. He's on hydralazine 10Q8, isosorbide dinitrate 10Q8, furosemide 40 milligrams a day, enalapril 5 BID, metoprolol tartrate 25 BID, spironolactone 25 BID, diltiazem sustained release 240 daily, aspirin 81, and pravastatin 10. On exam, he's breathless, sitting upright. His blood pressure is 155 over 95 millimeters of mercury. His heart rate is 105 beats per minute, and it's irregularly irregular. His weight has increased 15 pounds from his discharge just 2 weeks ago. His neck veins are distended to the tragus. He has bibasilar rales, ascites with hepatomegaly, and 2+ lower leg edema bilaterally with warm extremities. But he's really volume overloaded. His EKG shows atrial fibrillation, which is well known in this gentleman. He has left ventricular hypertrophy by voltages and no acute changes compared to just 2 weeks ago. His labs show a BUN of 27, a creatinine of 1.3. His hemoglobin is normal, and his NT-proBNP is 3,300. His troponin is normal. So he's on maximal therapy. Do you agree with that? Do you think he is?
Well, I'm not so sure he's on maximal therapy, and he looks like he's on a lot, as you said, a lot of relatively low doses of a lot of medications, and I wonder if it might be possible with him to increase some of those medications. So here's somebody who probably has heart failure for a number of reasons. We're not completely sure. He has coronary disease, but as you said, his LVEF of 15% seems out of proportion to the degree of coronary disease that he has. So this may be an underlying non-ischemic cardiomyopathy with some coronary disease overlying that, or it may be alcohol. He also has atrial fibrillation, and it's not clear how well that has been controlled over time. And he has a history of hypertension, which all of these can certainly contribute. So I would want to go back over his medications and maybe think about getting him on higher doses. It looked like he wasn't on a very high dose of the beta blocker, for example. He's curiously on the combination of isosorbide dinitrate and hydralazine, and he's also on an ACE inhibitor. And, he's African American, so certainly there's a rationale for the isosorbide and the hydralazine. But the ACE inhibitor as well, that seems a little bit odd. So
yeah, and I think it's always so hard for patients to have to take the TID hydralazine and isosorbide.
Yeah.
What did you think about his calcium channel blocker? Do you think that was he was on diltiazem? Do you think that's a good drug for him? I assume that his doctors were trying to treat his hypertension.
I think so, but I think we have a lot of other ways we can treat hypertension in him to not need to use a drug that has at least some negative inotropic properties. So I would probably want to get him off that. Certainly.
So you'd probably stop the diltiazem, try and give him higher doses of an ACE inhibitor, maybe higher doses of beta blocker. Now, I notice he was on metoprolol tartrate. That's not evidence-based, we always say in the guidelines. Would you change him? How strongly do you feel about that?
I think we probably ought to change him over to metoprolol succinate.
Or
carvedilol, which would be fine.
Right.
And then you'd want to up-titrate.
Right, up-titrate.
As he tolerates.
And do you think there's any point in trying to get him on a simpler regimen, sort of higher doses and fewer drugs? What's the minimum drugs he should be on?
Of course, you'd much rather him be on as few drugs as he possibly can and as few times a day as you can possibly get him to, because adherence is such a major problem with patients. And simplifying the regimen, make it easier for them to understand as well as take. You mentioned before the 3 times a day is going to be tough, and he's going to miss some of those for sure. It's going to be hard, I think, to get him on a once-a-day regimen completely, but a twice-a-day regimen is not unreasonable for a patient with heart failure like this.
So in this era of trying to keep patients out of the hospital and certainly preventing readmissions after heart failure, why do you think this man's being continuously readmitted? What kind of strategies could we use to keep this man out of the hospital?
Well, in addition to optimizing his medication, as you would, as we'd want to do in him, we also think about non-pharmacologic approaches in somebody like this. So, to what extent is he able to, for example, you mentioned weight gain recently. Is he monitoring his weights? Does he have a scale that is accurate enough that he can know if his weights are going up? And some patients, of course, are very well versed at monitoring their own weights and then adjusting their diuretic regimen based on those weights, with, of course, input from nurse practitioners and pharmacists and physicians.
What kind of strategies do you use for patients who might not be willing to go that step of weighing themselves and calling? Are there other resources that are available to a lot of patients to help with that kind of compliance?
There certainly can be, depending on the healthcare system and how well plugged in they are. And we certainly use nurse practitioners and pharmacists to help patients in this way, because they can't always get in to see a physician, and that can be very helpful as well. And there are, I think over the next few years, we will start to see newer technologies that will help manage patients remotely like this.
Right. So the referring physicians had thought that maybe this man should be considered for heart transplant since he'd been in the hospital so much. And they'd heard that patients that are in the hospital a lot maybe should be considered for advanced therapies. What do you think about this gentleman?
Well, I'm not sure, depending on how he does with optimization of his regimen. I don't think we'd want to make that decision until we are convinced that we have optimized his medical regimen enough so that we feel that he's now at the end of the medical rope.
Right.
And at that point, we might consider whether he would be a candidate for advanced therapies.
Yeah, I think he needs to be embraced in a heart failure program. So, Ms. Jones is a 26-year-old woman who was admitted to our hospital with acute decompensated heart failure. 2 years previously, she attempted to join the Navy. She was rejected because her heart rate was 105 beats per minute at rest. She had an otherwise excellent exercise tolerance, and unfortunately she was not referred for medical evaluation, and she went on with her life. 2 months prior to this admission, she noted increasing fatigue and breathlessness on exertion, but was still very active. She does not use alcohol or recreational drugs. There's no family history of heart failure. She has never been pregnant. On admission to the outside hospital, her EKG showed sinus tachycardia and nothing to suggest that this was a supraventricular arrhythmia. And on exam, she was mildly volume overloaded. Her heart rate's 115 beats per minute and regular. Her blood pressure was 88 over 50 millimeters of mercury. She had a loud S3, a displaced left ventricular apex to the anterior axillary line, and marked RV lift. Her extremities were warm. Her lab showed completely normal except for an NT-proBNP of 6,200. She had no anemia, no thyroid abnormalities, and her echocardiogram showed a markedly enlarged left ventricle and right ventricle with an ejection fraction of her left ventricle of 10% and moderate pulmonary hypertension. She was given IV furosemide with a good response, but her blood pressure fell even lower to 80 over 50 millimeters of mercury. Her heart rate remains at about 115 beats per minute, and she was completely asymptomatic and warm. Carvedilol was given and escalated over the next 2 days to a top dose of 12.5 milligrams BID, and her heart rate still doesn't change, still sits there at 115 beats per minute. She's tired, but she's now been in the hospital for a few days. Her physicians then follow the suggested guidelines and gave her ivabradine at 2.5 milligrams BID. She becomes profoundly fatigued and her extremities are now cool, and she's transferred to our hospital. Over the next week, attempts are made to diurese and optimize medical therapy, but her blood pressure really precludes any meaningful escalation of medications, and a right heart catheterization is then done, which shows a heart rate, again, of 115 beats per minute, blood pressure of 85 over 50, a right atrial pressure of 20 millimeters of mercury, pulmonary artery pressure of 65 over 48 millimeters of mercury, a wedge pressure of 45 millimeters of mercury, and a cardiac output of 2.1 liters per minute with an index of 1.6 liter per minute per meter squared. So, what are the next steps here, Scott, on this unfortunate young woman?
Yeah, what an unfortunate case. And it sounds like that she probably has a idiopathic, maybe even genetically based cardiomyopathy, and she might have had this for several years, and it goes to show how important conditioning is in heart failure, because she probably was in such good shape because she was exercising that she was able to sort of mask it for a long period of time, but clearly her heart rate was the first clue.
Right.
A sinus rhythm, a sinus rate of over 100 in a healthy person is clearly not normal and needs to be looked at. But in her case, I mean, here's somebody who needs her heart rate to be up because it's the only way that she's going to be able to maintain her cardiac output. And so she seemed to get into a lot of trouble when she was given first the beta blocker, but then it was really the ivabradine, the heart rate reducing agent, that ended up tipping her over the edge. So is she medically optimized at this point? So she's on a beta blocker, and presumably they, when she came to your hospital, they discontinued the use of ivabradine. But was she also on any other vasodilating medications?
She wasn't, and I think that was the dilemma the physicians had, is that her blood pressure was so low.
Yeah.
They were reluctant to give her a lot of diuretics and reluctant to give her any vasodilators. Yeah. So I think that was, as you said, this case was really insidious, and that finally she presented with really now heart failure.
Yeah.
And came to us on beta blocker and ivabradine, not a lot of diuretic and not a lot of vasodilator, and a blood pressure of 85.
Right. So presumably then, you did think about optimizing her medical regimen. Paradoxically, even though blood pressure is low, you can even improve that sometimes if you improve cardiac output by giving vasodilator therapy, but you can do that in a very measured way, using extremely low doses to start with and then titrate up. Is that what you did, Mariel?
So how long? I mean, so the amazing course in this young woman was exactly as you said.
Yeah.
We tried for about 2 weeks to get her on a reasonable amount of medical therapy. Despite the examination that I presented, she really had no peripheral edema, no obvious ascites, and yet we diuresed her massively. I mean, I don't know where the fluid was hanging. She was very thin.
Well, with a wedge of 45, certainly a fair amount was in her vasculature.
Somewhere, right.
Yeah.
And but despite our great attempts, we never could get her cardiac index over 2 even, and her wedge pressure was very difficult to lower. So we finally abandoned hope of trying to bring her back from the brink of cardiogenic shock, and she's now listed for transplant.
Yeah.
So I think, is this the kind of person that you would think about a ventricular assist device, or would you think about transplant, or how do you think about these kinds of patients?
Yeah, no, I think we would think about both of these options. I mean, she's young, and so she's a perfect candidate for a transplant, but as you know, transplants don't grow on trees.
Right.
And so there's going to be a time that she's going to wait, and there may be other factors that influence the timing in her particular case. So I think that I would think about a ventricular assist device for somebody like her, and of course that would potentially give her the option of getting out of the hospital and having some mobility as she waits for a transplant.
I think the final take-home message for me here in this case was, you're never too young to go get a physical examination and find out why your heart rate is so fast. It was a missed opportunity, I thought.
So this is a case of a retired librarian, Mrs. Jackson, let's call her. Not her real name, of course.
Yes.
She's a 70-year-old woman who presented with increasing shortness of breath on exertion. And what I mean by that is that when she walks one flight of stairs, she really feels short of breath. She doesn't experience chest pain, she doesn't have orthopnea, and she hasn't had paroxysmal nocturnal dyspnea. But she does complain that her ankles are swollen most of the time. She has a long history of hypertension. She has no known history of heart failure or hospitalization for heart failure. She denies syncope, pre-syncope. She does note frequent palpitations. She does note that her heart races occasionally for unknown reasons. Unfortunately, she's a smoker. She smokes 1 pack of cigarettes a day. She doesn't drink alcohol. And her mother had a history of hypertension and atrial fibrillation. On exam, she's mildly obese. She's got a BMI of 31.6. Her blood pressure is elevated at 156/70. Her heart rate is 78. It's regular. She, on exam, has a 2/6 systolic ejection quality murmur. Her jugular venous pressure is 8 centimeters. Her carotids are full. Her lungs are clear. She has moderate bilateral pedal edema. Her electrocardiogram shows normal sinus rhythm at 78, normal intervals, and just non-specific ST wave abnormalities. And her current medications include amlodipine, 10 milligrams once a day, and she also takes levothyroxine for hypothyroidism, 100 micrograms a day. When somebody like this presents to you, what are you thinking, and what would be the first step in the diagnostic workup?
So, if I had to guess, without knowing what her echo shows us, I'd be willing to go way out on a limb, not really, that this is probably HFpEF, heart failure with preserved ejection fraction. Elderly women by far own this disease. It is a disease much more commonly seen in older women. It's not completely clear why women get HFpEF more than men. It probably has something to do with the way our hearts remodel as part of any kind of stress. Men's hearts tend to dilate, and women's hearts tend to hypertrophy. And so for a given left ventricular ejection fraction, the left ventricular pressure is higher in women, which is why women have more symptoms of breathlessness and have more altered quality of life. But I suspect this is what it is. Most commonly it's associated with women that have hypertension, tends to travel with obesity. It tends to be associated with some lung disease, and this woman is a smoker. And the hallmark is usually some volume overload, so this woman has edema. And atrial fibrillation is a constant companion. So I wonder whether her palpitations were related to intermittent atrial fibrillation. So this woman is a walking stroke potential, or is somebody that is the bread and butter of cardiology, and certainly the other side of the coin of heart failure. So I bet that if we saw an echo, she'd have a preserved ejection fraction. What did she have?
Of course you're right. And she had an echo, and her ejection fraction was actually smack on normal at 60%. The echo also showed that her left atrium was dilated, and she had, as you suggested she would, a little bit of hypertrophy, left ventricular hypertrophy. Not whopping hypertrophy like we'd see in somebody with hypertrophic cardiomyopathy, but 12, 13 millimeters of wall thickness, not normal. Now, this is the kind of patient, of course, who these are fairly vague symptoms. How do we know this is heart failure and not something else that is causing her breathlessness? And she has edema, but she also takes some lodipine, which we know can cause edema. How can we be sure? Are there any other diagnostic tests that we could do, for example?
Well, absolutely. One thing that I do want to comment on about her echo, and I believe you were the first author on this wonderful paper from TopCat, a big study of HFpEF, that showed that all of the patients that were admitted to TopCat, their echoes didn't look all the same. And so we always look for an enlarged left atrium and a lot of diastolic abnormalities on the left ventricle, but that isn't necessarily what we have to see all the time. So I wouldn't exclude the diagnosis of HFpEF just because it didn't have the classic findings on echo. But of course we'd want to do an NT-proBNP or a natriuretic peptide, and I think that has been a real help in the diagnosis of HFpEF, is that if the patient has an elevated natriuretic peptide, and we have to exclude other reasons why she may be breathless, and certainly excluding significant lung disease. As you said, she could have edema for a number of reasons, and to make sure that there aren't any other abnormalities. The most important thing in this woman is to make sure she doesn't have coronary disease. Right. So she needs a stress test at the very least to try and make sure that this isn't ischemia that's causing her breathlessness. The classic way we make the diagnosis of HFpEF, though, is in someone with a normal ejection fraction and elevated filling pressures by doing a cath. But I don't think that's necessary to do in every patient.
Sure. So let's assume this is, in fact, what she has, that she's heart failure with preserved ejection fraction. We know her ejection fraction is preserved. It's actually even normal, because we would call it preserved if it's anything over, well, some people say 40, some people say 45, but in her case it was 60. And we think she really does have signs and symptoms of heart failure. What do we treat her with? We're so good at treating heart failure with reduced ejection fraction, and this has, as you know, been a disappointing area.
It has been. But I think we can aim towards symptoms, so I think she may benefit from a little bit of a diuretic. We certainly need to control her blood pressure for all those reasons. But most importantly, in this woman, we really need to make the diagnosis of intermittent atrial fibrillation because she will need to be on an anticoagulant.
So would you do that using monitoring? Would you?
Yes, we could do monitoring, Holter monitoring, or long-term monitoring.
Sure.
And I think that would be really important. In fact, it's mandatory.
Yeah, yeah, of course. What about other medicines? Would you use beta blockers, calcium channel blockers, ACE inhibitors, or ARBs?
All of those are possibilities to control the blood pressure. I think some people use ARBs to because of the data suggesting it reduces hospitalizations. This woman hasn't been in the hospital yet.
Yeah.
So I think we need to control the blood pressure, make sure she's not having atrial fibrillation, and use diuretics. I happen to use mineral corticoid receptor antagonists, but the study in that TopCat was disappointing as well.
Yeah, and it was disappointing in that we know that in the patients who we really think did have heart failure, it appeared to at least be beneficial with respect to hospitalization reduction. But I agree with you that we still don't have a therapy for this disorder.
Right.